Hello. Good evening, everyone. Hello. Uh, I am Vivek. I am part of HALEON Group, makers of Centrum Joint and Mobility. First of all, it's a pleasure and honor to welcome you for the Joint and Mobility Conclave, a program dedicated to advancing knowledge and collaboration in joint and mobility. A special welcome to our guest speaker, Dr. Nancy. And yeah, there she is. And our respected chairpersons, we welcome you. We are also honored to have all the doctors who have joined online from other centers. So really welcoming them all from other centers, and I think they'll be part of the discussion as we move forward. Today, I think also, before we start, I would like to request all the chairpersons, Dr. Nancy, to please come forward and join us for the lamp lighting ceremony. And before we start, let's mark the auspicious beginning of today's program. So can all the chairpersons and Dr. Nancy, if you can please come forward.
Yeah, I'll put it. Hmm. You have to share, is it? Well, okay. Okay. Good evening, distinguished guests. It's both my pleasure and honor to welcome you all to this HALEON Joint and Mobility Conclave. As a gathering today, as we gather today to share knowledge, learning, and spark new ideas, explore frontier of science, it's only fitting that we begin by introducing our distinguished chairperson and the speaker for the today's event. So we have a full uh, panel of experts, and I'm sure these are the well-known, most respected name in the field of orthopedics. So we have as chairperson Dr. P.L. Srinivas, professor and Head of the Department Orthopaedics, Osmania General Hospital, Hyderabad. We have Dr. B. Valya, Professor and Department of Orthopaedics, Gandhi Medical College, Secunderabad. Then we also have Dr. P. Chandra Shekar, Professor of Orthopaedics, Nizam Institute of Medical Sciences. And Dr. Jagan Reddy, Senior Consultant and Orthopedic Surgeon, Care Hospital, Hyderabad. Let me also introduce our international speaker for today. That's Dr. Nancy E. Lane, a distinguished professor of medicine and rheumatology, UC Davis School of Medicine, Sacramento, California. She's also professor of medicine and rheumatology at Stanford Medical School. So before I invite Dr. Nancy for her talk, I'll just take you through some data points, share some data, to provoke your thoughts on the burden of osteoarthritis in India and globally, and then we'll listen to Dr. Nancy of her talk. Okay. Oh, yeah. So if you see osteoarthritis, this is the burden globally. So globally, around 595 million sufferers of OA. And from last 3 decades, it has seen an increase of 132.2% in number of cases. So this is from data 1990 to 2020, which is projected to further increase by 74% for knee, 48.6% for hand, 78% for hip, and around 95% for other types of OA by 2050. Now, if you look for adults aged more than 70 years, OA is ranked as the 7th most common cause for years lived with disability. So all geographies, across the globe, as you could see in the right side of this, slide, all countries are affected by OA. Prevalence remains, different, varying depending upon the population and the gene pool, but the trend is that it is on rise across the globe. What about India? So in India, OA affects around 22 to 39% of Indian population and is a serious public health concern. So burden increased from 23.4 million to 62.3 million in the last 3 decades. So from 1990 to 2019. So if you see again, affects almost all geographies, all states of India, with prevalence higher in some than other. But the trend, is on rise. So with population, although we are still a young population as a country, but as the population grows old, the incidence is only going to increase. So what about the other parameters? So if you see on the severity of OA in India, over last 3 decades, 47% of Indian population have mild OA, whereas 35 have moderate OA, and somewhere around 17 is who have severe OA. The prevalence, as expected, is higher in women as compared to men. Approximately 40% of the population aged more than 70 shows OA, in which nearly 2% have severe pain and disability. Incidence of knee OA increases tenfold among ages of 30 and 65 years. And the contributing factors, risk factors, as we all know, are obesity, increasing age, gender, educational background, and occupation. Now, what is the disability cost of OA? I'll not go in detail, obviously, direct cost in terms of pharmacological treatment cost, adverse effect cost, healthcare provision cost, tangible cost in terms of quality of life impaction, indirect cost on absenteeism, reduce productivity, etc. But just to give you some values on the cost of management, so medical management of knee OA in India costs somewhere around 20,000 Indian rupees, whereas the surgical cost ranges from 1 to 5 lakhs in India. Just to give you what are the current options in terms of and the strategies in the OA management. So the strategies mainly focuses on reducing pain and discomfort to improve the quality of life, maintaining joint stability, and avoiding functional loss. So there are various therapeutic options available from pharmacological options like COX inhibitors, NSAIDs. Then we have intra-articular injection, hyaluronic acid, corticosteroids. We also have in India, especially, Ayurvedic, homeopathy alternatives, nor pharmacological options, herbs which are, for us at least, are under Ayurveda. So boswellia and other herbal, options are available. And then there are, as the disease progresses, surgical options available, but also are food and nutraceutical options, which are kind of, having place in the management of OA, which includes glucosamine, omega, and vitamin mineral, and UC2, which is a collagen. So this is just an overview of what, various guidelines across the globe, and more focus from the, guidelines coming from United States, place various therapies in the management of OA. So the darkest green is the strongest level of evidence, and the darkest red is the least level of evidence or strongly against use. So if you see across, major guideline, oral NSAID, topical NSAID, and intra-articular, corticosteroids remain the mainstay. Some of the guidelines recommend, oral paracetamol less than 4 milligram per day as the therapy, and other options like, glucosamine, chondroitin, although, all major guidelines have kind of removed them from the management, but some of them guidelines still kind of propagate them for use. So other options remain like topical capsaicin, tramadol, and opioid. So not very strongly favored for use by major guidelines. However, there is a trend. This is from a recent paper published in International Journal of Orthopaedic Rheumatology, wherein, they have given a step-up approach in terms of management of knee OA, and try to integrate the nutraceutical aspect in management of OA to reduce the dependence of NSAID because of the side effect, etc. So wherein undenatured collagen type 2 plus minus paracetamol and other NSAID are given as a step-up approach in management of osteoarthritis. Now, just to give you a brief, and Dr. Nancy, who's the expert here, would dwell in detail about what UC2 is, what collagen is, and how different collagens are different, and what is the data. But the important point about undenatured collagen is that it is extracted using a patented process, which is what is responsible for its mechanism of action. So the image here shown actually highlight how the triple helix structure of collagen and the antigenic epitopes highlighted here as the golden balls are responsible for triggering the antigenic response and hence the mechanism of action. So any process by which this structural integrity of the collagen is lost, the mechanism of action will gets compromised. So the triple helix structure, the epitopes are the bioactive centers which stimulates the pair patches present in the intestine, in the mesentery of the gut, which is what is responsible for initiating the tree regulator cells in terms of eliciting the anti-inflammatory and other responses that are seen. This structural integrity also prevents the collagen from getting destroyed through gastric pH and being bioavailable for its action in pairs patches. So this is just to show you comparison that the molecular structure, the cross-linking, the collagen triple helix, and the epitopes, the structures which I just highlighted, are maintained in type 2 collagen, which is undenatured type 2 collagen, for its action and its bioavailability to kind of show the anti-inflammatory action which we very well associate with it. So if these cross-linking or any of the other three parameters tend to get lost, the the overall mechanism of action is hampered. So this is what is the difference between, UC2, which is a patented molecule from the innovator called Lonza. It is a US-based organization, and the complete source come from Greenwood facility, which is only located in US. So everywhere when you see UC2, it is coming from the US, and hence the quality standard, etc., are maintained. And of course, it has its own limitation in terms of the transit time, etc., which we have to kind of take care of. But the important part is that if you see these diagrams, this is the UC2, and this is the native collagen, which is not UC2. UC2 maintains the structural integrity, whereas other native collagen tend to lose the structural integrity. So if that structural integrity is lost, the antigenicity is lost, and hence the higher need, the potency is lost, and hence the higher need. Say, for example, other undenatured collagen, the dose required would be 1.5 to 6 times that of UC2 to elicit the same response, because though the antigenicity, the structural integrity of UC2 is lost. So this is again coming from a comparative study wherein they have compared UC2 and other native collagen. And Dr. Nancy would be, talking of these in detail. Just to give you a glimpse of what we represent as organization. So we have Centrum Joint and Mobility. So it is a combination of collagen type 2, UC2 type 2 collagen, which is 40 mg, along with vitamin K2 MK7, again a clinically proven vitamin K2 minaquinone 7, which is 55 mcg. It also has calcium and vitamin D and other minerals like zinc, manganese, and copper. So, from joint and mobility point of view, all those that are required to maintain the joint health. So this is the combination once daily dosing. So just a few points on, vitamin K2. We all understand, vitamin K2 is required for bone calcification. It being K2 MK7, it has a higher, half-life. So once daily dosing. It also prevents calcium deposition from arteries, the risk that usually arise with calcium use and vitamin K use. So because of the K2, because it's micro encapsulated, so the chances of calcification tend to reduce. And of course, it reduces the risk of fracture, and the data exists in terms of how it improves the bone mineral density in postmenopausal women. And the other minerals, I think I'll not dwell in detail. We all know the importance of these in terms of maintaining the bone and muscular health. So that's it from my end. May I invite Dr. Nancy for her talk now.
We're going to try to use the podium. We'll see how it goes. If it doesn't work, we'll switch. Okay? All right. So, well, good evening, everyone who's here in the room with us and who are listening from afar. It is my pleasure to talk to you tonight and to build on the wonderful background that we've been given now to talk about novel treatments for osteoarthritis, but I'm going to give a focus, are we done? Okay, on UC2, undenatured type 2 collagen. Okay. Nope, that's not working. Okay. It's not moving. Okay. I'd like to start by a quote that is often used to describe the management of osteoarthritis. If there is an illness for which people offer many remedies, you will be sure that particular illness is incurable. And I believe everybody here today would probably agree with me there. Okay, but let's talk a bit about how we manage osteoarthritis pain of the knee right now. These are guidelines from the American College of Rheumatology and are very similar across multiple musculoskeletal subspecialties. We first go with that non-pharmacologic therapy, education, weight loss. The GLP-1 agonists are really making a great, are doing very well at that. physical therapy, aerobic exercise programs, and then we go on to pain management. Acetaminophen, which may or may not be helpful, over-the-counter non-steroidals, and nutritional supplements. If those don't work, we add on NSAIDs, both oral and topical, including the COX-2s, as needed, opioid analgesics, and surgery at the last point. Now, during those times of flares, we may give intra-articular steroids and hyaluronan, and those all help to make the patient better a little bit in their own way. Now, how I got in, if you will, to the nutraceutical world of treating osteoarthritis was I participated in what turned out to be a landmark study on glucosamine and chondroitin sulfate. Did these two medications, alone or in combination, really help people with painful osteoarthritis of the knee? And as you can see, our results were in the New England Journal, so people were very interested in our result. This was a very big study, multiple centers, and we were very lucky that study patients were able to complete our study. But what we found was not necessarily what anyone expected, and that compared to placebo, glucosamine with or without chondroitin sulfate did not separate from placebo. And the only medication that really worked in these NEOA patients was Celebrex. So we started to scratch our heads and say, maybe this wasn't going to be an effective therapy. So now let's go and talk a bit about cartilage. Cartilage is an amazing material because it's made up of collagen, proteoglycans, and water. And it's like a sponge. As most of you know, when we put weight on our joints, out goes the water, and when we take the weight off, in comes the water again. And it really works because of this incredible complex and efficient structure. Now, the chondrocyte is the only cell in that cartilage, and that chondrocyte is very special and interesting. It both makes the matrix that it sits in, and it degrades it. And in normal people that don't have osteoarthritis, that works very well. However, and I want to make a comment about the collagen in cartilage. It's collagen type 2. Collagen type 1, that's in bone. Type 2, that's in the cartilage, and that gives the cartilage its backbone and structure. So how do we get osteoarthritis from this in this joint? Well, it probably starts mechanically, and that releases some probably fragments of the collagen that set up the immune system that then reacts with inflammatory cytokines that destroy the cartilage, and the end result is cartilage degradation. So now I mentioned inflammation. Inflammation is driven by T cells. And although many of you in the audience are orthopedic surgeons, you can take a little tutorial with me for just a moment on T cells. Okay. There are three major types of T cells: Th1, which are pro-inflammatory, Th2, which are anti-inflammatory, and Treg cells, which are also anti-inflammatory. And these Treg cells have become very important for us for many reasons. Now, why are Th2 cells anti-inflammatory? Because they make IL-4 and IL-5 and IL-13, and that dampens down inflammation. Why are Tregs anti-inflammatory? Because they make TGF-beta and IL-10, which also reduce inflammation. Okay, now let's talk about the mechanism of action of UC2, undenatured type 2 collagen. All right, this is the proposed mechanism of action. The patient takes the UC2 and when it gets to the GI tract, it gets absorbed, goes through the lymphoid tissue, and then the mesenteric lymph nodes, and then the Treg cell, that anti-inflammatory T cell, releases the inhibitory cytokines, IL-10 and TGF-beta, reducing pro-inflammatory cytokines. What happens? Reduce pain and inflammation. Now, that was a lot to say. Let me give you now some of the data to support that. A number of years ago, we did a study in a rat model of osteoarthritis. Now, shown here in this slide, it's a little bit busy, but I think you can follow along. we used rats, we injured their meniscus, and then we gave them UC2 or placebo. And then we gave them the medicine for 8 weeks, which is a long time in a rat's life. And then we looked at the outcome measures of how much weight the rats could put on that joint, looked at x-rays, looked at histology, looked at bone histomorphometry. What did we see? Well, you can see here that compared to the placebo, that the UC2 actually treated rats had less cartilage, or had more cartilage than the placebo, I apologize. And then when you looked at how much weight the rats could put on their rear leg compared to placebo, the rats treated with UC2 could bear more weight, meaning they had less pain and the bone structure remained intact. Now, what is UC2? It's undenatured native type 2 collagen, comes from an animal. That's important as we go forward to distinguish it from other types of collagens that are sold. What are the differences between UC2 and other type 2 collagens? It's an intact structure. It's recognized by the body. And as I will show you in more detail, induces oral tolerance, which is most likely part of the anti-inflammatory effect. However, regular or denatured type 2 collagen is different. The structure's destroyed. There's no recognition by the body. And to date, there is no oral tolerance that has been reported. So now let me go over some clinical evidence. And some of you may say, well, wait a minute, we just switched into rheumatoid arthritis, and we did. Over, about 30 plus years ago, David Trentham at Harvard and his research group did a very important study. How do I know it's important? Because it was published in the journal Science, one of the most prestigious journals that we have for scientific discovery. And what he did was he used oral type 2 collagen in the treatment of rheumatoid arthritis. Now, let me tell you a little bit about this study. It was a proof of concept study, so it'd be like a phase 2 study. It was double-blind, placebo-controlled phase 2 study, 60 patients with active rheumatoid arthritis. They were taken off all their immunosuppressive drugs, which in those days was only methotrexate and Imuran, and randomized to 3 months of treatment with either placebo or oral undenatured collagen, chicken collagen, UC2, and he started it at a low dose for a month and then increased it. Now, if you look at my slide here, you'll see that these patients, these study subjects really had quite active disease. They were in their 50s. They'd had their disease for 10 years. They were rheumatoid factor positive, and they were taking prednisone and immunosuppressive agents. What did he find? Well, this is pretty interesting, and I considered it unexpected. Look at the baseline values, number of swollen joints in the UC2 group or the placebo. You can see a difference in 3 months, reduction in the number of swollen joints. The number of tender joints went down by 30%. Morning stiffness, which is that measurement of inflammation in the joints, went down from 155 minutes a day down to 50. That's a huge difference and really didn't change in the placebo group. And the patients who thought their disease had improved went up over 30%. And sedimentation rate, which is a very objective measure of systemic inflammation, went from 40 to basically 2. So this is really incredible results for a rheumatoid arthritis study. So after Dr. Trentham did that study, many investigators across the world started to say, well, maybe we could use UC2 for osteoarthritis or musculoskeletal pain. And let me show you a few things now. In the past 12 or so years, there have been a tremendous number of studies done in healthy subjects, 12 studies done in OA patients, some animal studies. The total number of human subjects that have been studied over the last few years is over 2,000. So Then age range 20 to 80 in 8 countries, which point we have a database at which to talk now. And I'm going to show you some of that data. So one of the first studies that was done with UC2 was done in what you would call healthy, active individuals who had knee pain from over-exercising at the gym. And what they found was that probably had a few more females than males, which does happen with knee pain. These were people in their about mid-40s. They weren't heavy. And the study went for 120 days. And they looked at some interesting outcome measures, excuse me, some very interesting outcome measures. Improvement in knee function, which is range of motion, and time to the onset of knee pain when these study subjects were going up and down stairs, and how fast the pain went away. Let me show you what they found. If you looked at the patients compared to placebo, the UC2 patient shown here in this slide, it took a while. It took about 30 days. And then you see that the amount of range of motion continued to increase in those UC2 patients compared to the placebo. But that's not all. Look at the baseline WOMAC scores. WOMAC is a measure of 3 things: knee pain, knee stiffness, and activities that you can do. And as you look along here, you see again, after 30 days, you start to see more of an improvement in the UC2 subjects than the placebo, suggesting it takes a little while for this to work. And then when the study subjects went up and down the stairs, you can see the time to recovery was much, much shorter in the UC2 subjects compared to controls. So your over-exercising healthy group of patients that come in with knee pain, this could be very effective. And as I mentioned, when they did the stair climb, their time to induce joint discomfort increased with the UC2, and you can see it clearly at 60 days and stays there out to 120. Very important. Okay, but those are our healthy knee pain patients. What about patients who have osteoarthritis? What is the data there? Now, this is one of the first studies done in India looking at just the safety and efficacy of UC2 in osteoarthritis patients or subjects of the knee. Now, this is a small study of only about 50 patients, about 60 years of age, and most of them had more left than right knee OA. What they found was, again, as they went out from day 0 to day 90, that it started to take a little while, but that you saw the UC2, there was a reduction in pain and stiffness and activities compared to placebo. And so that was a proof of concept study, which brought us to the next study, which was exceedingly important, done in 2016, where we looked at Undenatured type 2 collagen supplement, and it was randomized, multi-centered, double-blind, placebo-controlled study. These patients, we had about 186 patients. We looked at WOMAC, and you had 13 centers here in India. And what you can see here again is that you start out with placebo. We compared it to glucosamine chondroitin and UC2. No real differences between the treatments at 30 days. But as you went out, at 60 days, it separates and continues to 180 days. You can see then that UC2 is significantly different from the other treatments and important, clinically important too. However, there have been studies outside of India, and a very important study was actually done in Brazil with Latino patients. And again, they randomized these study subjects with osteoarthritis of the knee to UC2 or no UC2, placebo. They had 100 subjects, and they looked at the WOMAC, but they also looked at SF12, which is a very good health-related quality of life measurement, and pain. And they went out 3 months. Now, this data is also very, very interesting. You can see at baseline, the VAS pain scores weren't different, but you went out 90 days and you can see the UC2 patients had 50% less pain. And in SF12, how they were functioning, much better than the glucosamine patients. And WOMAC, again, at 90 days was much lower, much improved compared to the placebo. So these studies begin to tell a story that this supplement, you need to keep taking it. You need to go on more than a couple of months to see the difference. Now, I wanted to show this as one of the last studies because it really breaks down the pain parameters, the stiffness parameters, and the function parameters that we look at when we assess the WOMAC in these OA patients. This is a small study. It's only 40 subjects, but these subjects were randomized to either UC2 or glucosamine. And what you can see at the end of 90 days, looking at this slide, is in every measure of pain, the UC2 patients did better. With stiffness, the intensity of the stiffness was different, and the functional parameters, bending, walking on a flat surface, were all better, more improved with UC2 than glucosamine. So my last study, I just want to say, sometimes we wonder if ethnicity makes a difference. So this is, again, a study of 100 Asian patients with NEOA, and they're just compared to placebo. But again, what do you see? Day 30 on, UC2 is significantly better in WOMAC and in pain scores in just Asian patients. So I want to summarize these studies. What do these studies tell us about UC2, undenatured type 2 collagen? You use it once daily. The proposed mechanism of action is to activate anti-inflammatory signals in the OA joint. It's effective. It reduces joint pain, stiffness, and improves function in patients with mild to moderate NEOA or just knee pain. This was observed across different ethnic groups, and to date, there are no apparent safety signals with the oral ingestion of the UC2 collagen. And I want to stop there and thank you for your attention. I got it done. Okay.
Thank you. Thank you, Dr. Lane, for the wonderful, insightful talk. No, it's not you. So may I invite our esteemed chairpersons also to join us on the dais. We'll invite questions from the audience here, and we also have the locations joining. We'll see if they would like to ask, or if I get the questions, I'll verbalize it to the panel. Yes, sir. Maybe I'll invite, and then we'll also need your insights, etc., to kind of answer these. So anyone from the audience, please feel free to raise
From
your
Madurai,
hand.
sir.
We'll bring the mic to you, and you can ask the questions.
From Madurai. Is it audible, sir? அவங்களுக்கு கேக்குமா?
It's so clear.
Okay. Meanwhile, I'll start from a few questions that I have received from the sites.
Okay.
And then as they feel comfortable, they can again come back and ask. So some of the questions, so one was maybe to Dr. Lane in the panel, considering that UC2 is a nutraceutical, so what is the duration of use that usually recommended to see any clinical benefit? That's the first part. And the second part is, what should be the recommended duration of use?
Okay,
So
well,
Dr. Lane first, and
I will start.
request you to also add.
I will start that, and then I want to hear from my colleagues here on the panel. From what I can tell from the data and in my patients, I tell them that you really need to take it for at least 3 to 6 months to get the maximal benefit. Then if they see the benefit, they can continue it indefinitely. There's no toxicity to it. The only concern is whether the efficacy would wear off if the disease got worse. But if you think about the mechanism of action, it takes a little bit of time for the immune system to get revved up into this anti-inflammatory state. So a few months for sure. And my colleagues, what do you think?
Yes, yes. Yeah, 3 to 6 months is ideal to see the result of this, especially type 2 collagen. So once response is good, I think we can continue it further.
Basically, my experience with this undenatured type 2 collagen is very limited. But what I have seen is we get KL2 patients around 45 to 50 years of age. And a long-term usage of any painkiller in such age is not good. So if this is not giving any gastrointestinal side effects, the usage of around 3 to 6 months is okay. Not beyond that, it is not much useful in our society.
So in my practice, we will tell at the beginning that it's a nutraceutical, it is not a painkiller. You won't get pain relief on the day or immediate. It takes some time to act. We have to try minimum 1 month. You see any difference. If you notice some difference, at least use 3 months and nothing harm to continue. If you feel better with that nutraceuticals and denatured type 2, you can continue.
Initially, it will be started with some supplements.
Anti-inflammatories along with that anti-inflammatories.
Yeah.
If it is in a lot of pain, we have to control the pain with NSAIDs along with this. And once the pain has come down, they can maintain the dose of nutraceuticals.
In your older patients, do you start with like UC2 and a topical NSAID, or do you go with the oral NSAID?
Yeah, we depends upon the profile of the patients. If it is quite elderly with diabetic CKD patients, we are very cautious about use of NSAIDs. We try to use a bit of tramadol and paracetamol, not NSAIDs, and start with the nutraceuticals and then see how it works. We'll go slowly. And we have disease modifying factors like weight reduction, physiotherapy, knee splints, offloading braces, like that we will recommend simultaneously.
Good.
Dr. Nancy, I have a small question. Do you recommend high dose of nutraceuticals, but type 2 initially like a loading dose and maintenance dose in your practice?
For the UC2 or the
UC2,
NSAID?
UC2.
No, what I do is I just start it once a day.
Yeah.
Like the Centrum, it comes, the supplement or the,
Yeah.
it comes in one dose. I don't
Yeah,
I
but
don't give a loading dose. And the reason is I don't think it would matter because there's no data to show that a higher dose gets the immune system going anyway. So I just go ahead and start it. But I tell the patients it's very important.
NSAIDs, what about NSAIDs? You add NSAIDs? or not?
Well, I start with topical and if,
Topical only.
and then in the first few months.
Oral NSAIDs. you
Well,
don't
I
add.
start with topical, then if I have to go to oral and then, but I tell them that it's going to take a while, that the UC2 is not fast. You see very clearly, it takes 2 to 3 months to get the effects going. So I get them through it with NSAIDs as needed.
Dr. Nancy, in our Indian system, other competitive brands, they recommend little bit of loading dose. They said take a PD for 15 days and followed by OD. Is it scientifically applicable or it's proven, these
Yeah.
nutricals?
Yeah, UC2 can be added to anything and everything. You can give a steroid injection, you give hyaluronic acid. It will work by modifying the immune system and getting some anti-inflammatory action. But it's going to take a while. I don't think you can speed it up, and the other analgesics and anti-inflammatories should just help the patient till you see if there's an effect.
Maybe I would like to add here. So there are various formulations available in Indian market, and they would have their own recommendations to use.
Mhm.
But for undenatured type 2 collagen, which we have, which is from Lonza, which is a US patented, process patented molecule, the recommendation across the globe, and it's not only in India, across various geographies where it is available, it is 40 mg once daily. And there's no as such need for, kind of having a loading dose and to, subsequently reduce. The recommendation is that this is the dose across the therapy.
Here,
Yes. sir.
this is to sensitize the oral tolerance is the thing, no?
Yeah.
So where is the point in giving the loading dose? We have to sensitize the T cells,
Yeah.
oral tolerance.
Correct.
Yeah.
So
Sir,
I don't think there is a loading and
Yeah. That concept, yeah, does
Correct.
exist. Maybe for some other molecule,
They may
some
have.
other nuance, but not for UC2 for sure.
Sir, is it related, linked to the body mass index? Some big patients, you need to give additional 40 mg or 60 or something, or universal for all patients?
Yeah. So, sir, currently the data exists and the studies exist with 40 mg. That remains the, recommended dose. So it is not associated with, that much variance in, body weight.
Is there any relation to the age and grading of the arthritis?
At this point, we don't have data to show structural, whether it slows the structural progression. However, I generally believe that if the pain gets better, that it's probably not getting worse. Because that's walking on a flat surface, which is, one of the WOMAC questions is pretty good. It's getting worse. You're not walking well. And I think we all need to realize that patients with very advanced OA, that this is probably not going to do much, but we're
Yeah.
talking about the ones that still have some cartilage, still have pretty good quality of life.
Yeah.
This may slow the progression.
So initially it is ideal. Yes.
So, have one more question coming on similar line, Dr. Lane, to you and the panel. So in terms of, UC2 use in osteoarthritis, you already, elucidated and you showed the data. What about those which are apparently healthy, those with, stress joint, like, gym goers, or those who, walk a lot, or those who do physical activities, increasing stress to the joint? Is there any evidence for UC2's benefit in such group of patients? So those apparently healthy individuals.
Well, if it's the overuse injuries of the athlete, if that's the ones you're talking about, where you overuse the knee, you go cycling, you do a marathon, your knee hurts. Yes, that's where the data shows it's actually very effective. Yeah.
Sir, in my practice, articular cartilage is aneural, avascular, alymphatic. It is pain insensitive. You won't get any pain with articular cartilage. If you have layered superficial layers tied up to Tideman zone, if it is Tideman zone is exposed, then it is exposed to neural ends, patient will get pain. In a healthy individuals, if the articular cartilage is intact, there is no point in giving UC2. Because UC2 works, only Treg cells will go and repair the damaged cartilage so that it decreases the inflammation and this. In a normal things, when the articular hyaline cartilage is intact, there is no pain and no point in giving UC2. If they have articular cartilage defect like osteochondral lesions, then there may be a role. No preventive.
Okay.
No prophylaxis.
Yeah. Not as a prophylaxis, but because, there are people who go to gym and, they feel
Yeah.
stiffness in joint, which might not be osteoarthritis per se. So
Well,
from
I
that point,
think
don't
in
think
terms of prophylaxis, if someone goes to the gym and is sore, and then they decide, okay, they could take the supplement and see if they feel less sore after the gym, they should take it. We don't have data for it. They should take it.
What is the longest period of this UC2 usage? Longest usage in a particular individual or a
How
group?
long?
Yeah.
Duration? Oh, yeah, I think I have patients that have been on it for 5 years, 6 years. I mean, if they, it's like supplements, nutraceuticals. If the patients feel they're getting something out of it and they continue it, there's no toxicity to continuing it. Whether it changes anything, I think that hasn't been studied, but symptomatically, it appears to continue to have its effect? Those are great questions that it should be
We
studied.
have not observed any complications. Side
No,
effects.
no, the side effects aren't there and they're not there. If they can tolerate it, they do fine on it.
Youngest age you have used and oldest patient. Youngest and oldest patient.
Youngest
Where you have
patient,
started.
Oh, yeah, okay. I've used it in 25-year-olds,
25
the
years.
gym rats, and I've used it in 95-year-olds.
95 years also.
Is there any contraindication for this drug, like Crohn's disease?
I no, but I think, you know, obviously there will be some patients that might have a sensitivity to the undenatured type 2 collagen. I haven't seen it, but you know, there's always a patient that can have some sensitivity. But no, it hasn't, I haven't seen it. It's a really good question. Does it activate Crohn's? No, in fact, it possibly could reduce the activity depending on how much of its action is right there in the mesenteric lymph nodes. I wouldn't call it an indication, but I haven't seen it. I haven't seen a flare of inflammatory bowel disease. Very good question.
When you used at the age of 95 years, was it helpful?
I think so. They kept taking it, you know, but this was my 95-year-old was sort of what we call in California a health nut, you know. If it was a supplement, a nutraceutical, this wasn't the only one they were taking, but they liked it. Yes.
Okay, so we are receiving few questions. Maybe I'll ask the locations to, unmute themselves and ask the question. Hope that's okay.
Yeah, yeah.
So I'll request Lucknow. You can please go ahead, unmute yourself and ask your question. We'll bring them on screen, right? Yeah. Yeah, we can see you. Please unmute yourself and. It's not unmute. We can't hear you.
Okay, this is Dr. Subrat Verma from Lucknow. Regards. Just wanted to ask that undenatured type 2 collagen is given for protection of cartilage. It's a type of chondroprotective. Am I audible there?
Yes.
Yes.
Okay, so we know that knee carries its whatever nutrients we are giving to the knee, they are given through diffusion. Synovial fluid is very much necessary for that. So first is whether it will work in advanced arthritis like grade 3, grade 4. Second, do we need to supplement it with oral hyaluronic acid or intra-articular at a certain period of time for better bioavailability? Because the whatever nutrients we are giving to the knee, to the cartilage, as one of the speakers mentioned, that's aneural, avascular, it doesn't have any pain. So if it's avascular, the only thing which carries the nutrients inside is the synovial fluid. So what good is UC2 if it is not supplemented without hyaluronic acid?
Hyaluronic acid. is
Hyaluronic.
what. You got the question?
Yeah, you need to repeat it.
Should I repeat?
Yeah.
So I think the first question was, first part was that how long to use. Second is that considering that everything in the joint is through the synovial fluid,
Right.
is there a need to use hyaluronic acid
Okay.
so that it
Okay.
facilitates?
Okay. Got it.
Yeah.
I got it. Okay. I guess if a patient has osteoarthritis and they're benefiting from the UC2, I continue it. If the pain gets worse and they think it's not helping, then that's a decision that you make together, but there's no toxicity to it per se. So it's pretty safe. Now, I will say that I have given patients hyaluronic acid injections who also are taking UC2. And I've also periodically given them steroid injections and they continue their UC2. It tends you know, it's like any medicine. It doesn't work for everyone, but in those that seem to get benefit, there's no reason not to continue it and add on as needed other therapies.
Yeah, that's good. Yeah. Anybody?
So that
Yeah, you
question,
want to add, sir, anyone?
nothing,
Yes,
sir.
good.
In a severe osteoarthritis,
Yeah, that was the second part.
we will tell that it may not work,
Okay.
but if the patient insists, we will give
Okay.
and see. At least the percentage of inflammation may come down. The patient may not get full relief, may get partial relief. And plus or minus hyaluronic acid injections, visco supplements can be given.
Okay.
And we will warn them that you are reaching the end. You may be a surgical candidate for a knee replacement or some other surgical intervention
Okay.
in
Thank
severe
you.
arthritis.
Yeah. Thank you so much. Any other question from Lucknow before we move on to the next location? Okay.
We are done here.
Thank you so much, sir, for asking your question. We move on now to Guwahati. So you can please come off mute, and we have Guwahati as well, right?
Got a turnout. I'm so
Yeah.
impressed. Do we have another question?
Yeah,
Can you-
yes.
Hello, can you hear me? Hello, can you hear
Yeah,
me?
we can hear you.
Okay, this is Superior from Guwahati. Greetings. And my question was, how long can you continue it? What is your longest prescription?
How long to continue?
Yes. What is the longest prescription?
So the question is, what is the longest duration?
Longest
you can
duration
use?
of prescription?
Yeah, just now we discussed with Dr. Nancy. She
Yes.
told in her experience, 5 years, she told.
I think I probably use it in some patients 5 to 7 years.
Yeah.
I don't know that they've taken it all the time, but again, it's not going to cure the disease. It has a disease modifying effect. If it works, patients continue to take it. If they continue to get more, if they have more pain and more disability, then you have to figure out if you're going to add, you know, additional therapies. But if a patient responds and there's no reason not to continue it.
So we can continue continuously. You know, we can prescribe it continuously at a stretch for 5 to 7 years at least. If the patient is responding.
Sorry, we didn't get your question. Can you come again, please? Yeah, we
So,
can hear you, but it's not very clear.
Can-
Come again,
Can
please.
we prescribe the molecule?
Sir, we are in Hyderabad, they are in Guwahati. It's a very long
Yeah.
distance.
Okay, no worries. So can you just post your question in the chat? Maybe I'll read and verbalize because we are not able to, you know, comprehend what you're saying. So thank you so much.
Great, thank you.
Yeah, just put it on chat. I'll verbalize and you'll get the answer.
Probably Bangalore or something we can get easily
Sure.
because it's a short distance.
Yeah. I have other sites. So Hubli can go next. Anyone in Hubli who want to ask can just
I think we should make
unmute
a
and
point
please
that
ask their
this
question.
doesn't- You don't use
good
this
evening, sir.
necessarily
Can you
alone,
hear me?
no, you add other things like
Delegates, please
acid,
maintain the
et cetera,
silence,
from time
please.
to time. But in some patients, it would be
Good
helpful. I
evening.
think that
I'm
Please settle down, please.
to make sure that we.
Yeah.
Good evening.
Yeah.
I'm Dr. Santosh from Hubli. Can you hear me?
You need to be a bit louder. We can hear you, but not very clearly. Can you please
Okay,
be a
now
bit
can you hear
louder?
me? Yeah, now can you hear me?
Yes, go ahead,
Yeah.
please.
Yeah, I want to congratulate Dr. Nancy for a good talk on the mechanism of osteoarthritis and how UCII acts on cartilage degeneration. We have got two questions. The first question is, if it prevents cartilage degeneration in the knee joint, does this also prevent cartilage degeneration in the hip joint? Because we see loss of osteoarthritis, secondary and primary in the hip joint. Can she put some comments on that one?
I think the question is, what about other joints with
Yes,
osteoarthritis?
exactly.
Great question.
Yeah. Any regeneration?
Right, yes, well, the long story made short is my patients tell me that other joints and musculoskeletal ailments feel better when they tend to respond, if they're responders. But I haven't yet seen a study where they've collected data, say, on all the anatomical sites that actually have pain. So I think the answer is yes. I use it for osteoarthritis of the hand, for the hip, back pain. But there haven't, and my impression is a number of patients do respond, but there haven't been good studies on that yet. So you have to do some of your own experimentation.
Thank you. Thank you, Dr.
I
Nancy.
think it will works for other joints also, sir, like shoulder arthritis or hip arthritis.
Yeah.
I think it works because it is not only targeted for knee, unless we have T-reg cells applicable only for the knee,
Yeah.
but it's not.
From
It
mechanism of
affects
action, it makes
whole
sense.
whole body. For example, like if you put a patch of fentanyl patch, it works all over the body. Same like that, sir. It works all articular cartilage wherever is there. It works. But be more focused on the knee joint only because that is the main
Affection.
incidence and prevalence is more in the knee arthritis, especially in our say Indian scenarios.
Okay. Thank you so much.
My
Any
second
other question?
Yeah, my second question is, I think because it is mentioned in the label a red symbol, so I think India being a population of vegetarians and vegans, so I think it is a non-vegetarian source. So are there any plans to get a vegetarian source so that the larger population can imbibe Centrum joints? Any comments on that one?
So the question, maybe I'll put it to you as well, Dr. Lane. He's asking that it's a chicken source as of now. So any, because we have substantial vegetarian, especially even you heard from yesterday, right? Is there any other or similar, non-animal source for UC2? So maybe first we'll answer that. And then is there any other way that we can, get UC2? Which is not animal source?
Well, and the short answer is no, it is of animal source. So that's a discussion that one has to have with their patients. Sometimes some vegetarians will decide to try it, but otherwise, no, we don't have a non-animal source that we have data on or so far that we have. Okay.
Sir, we experience the same thing, sir. When we write it, they go, they buy the box and they bought a red arrow, red triangle. They will come that, sir, I am pure vegetarian. I can't take.
Would that be for other medicine as well, right, sir? I mean,
Yeah, it is other medicine also. But especially in nutricils, most of the companies are having red
yeah,
triangle.
yeah.
But we'll say that this is a genetic engineering, not direct non-veg. But few will convince and they take, few may not take.
Okay. Okay. So hope you got the answer. So if we have any other question, we can take. Otherwise, we'll move to the next location.
Good evening, faculty. Can you hear me?
Yeah, go ahead, please.
I have two questions. First one is, can we give UC2 along with the platelet plasma injection? As we have taught that PRP naturally heals the cartilage if it is in stage 1 or 2, early osteoarthritis. Can it be supported with PRP injection, UC2 therapy? And my second question is, can we take UC2 as a preventive measure, like we turn into 45 years of age, 50 years of age, or we are doing heavy workout, weightlifting? Can we take it as a preventive management?
Okay, well, I'll take the first part, and that is that you can give UC2 with PRP. They work through different mechanisms, so I don't know statistically if it would be additive or synergistic, but I think that they work through different mechanisms, so I think you can give them both. And then you asked whether it would prevent disease. Well, that's a tough study to do, and I don't think anyone's done it, but maybe you could try it in your practice and let us know. Okay.
Okay, thank you, ma'am.
So yeah, if you want to add, please.
Sir, what a nice question, bit controversial about PRP. PRP works for grade 1, grade 2, some papers suggested, but there is no definite evidence that PRP works. But you can try PRP as an intraarticular and UC2 oral. You can give combination. There's nothing wrong. It may have synergetic effect. You will get synergetic effect and good relief. Can. And the other question is about prophylactic use of UC2.
Yeah.
I was in UK for 14 years. In UK, they used to buy big bottles of chondroitin sulfate and glucosamines available over the counter, like Holland and Barnett. They go, they will buy, and they'll take that medications, glucosamines and chondroitin sulfates. At the time, UC2 was not available over the counter. I don't know now it is available in US over the counter or not, but people used to take around 50 plus, 60 plus. They used to take glucosamines, chondroitin sulfate, and cod liver oil, fish liver oil. They used to take as a prophylactic. But India, I don't think they will take because one is a cost thing and two is availability. These two things. But most of the kids, they go to US and UK. They come once in a year. They will bring a big bottles of glucosamines and chondroitin sulfate. As a respect, they will give to their parents. You take this. They will come to our clinic. Sir, shall I take these medications? So we'll say that it's only nutritional supplements you can take.
Good evening.
Your comment of is it available? So UC2 in some of the market is available over the counter.
Okay.
Yes.
Good evening, ma'am.
In India also it is a food supplement. So
Yeah, food supplements.
yeah, it's
Can
not
be
a drug. Yeah.
Good evening, ma'am.
So we can't hear
I
you,
have a
sir. You
question.
need to unmute.
Yeah.
Can you please come again?
He is talking, right? We
I have a question with Nancy, ma'am.
can't hear you.
Hello.
His
Can
mic
you
is
hear me?
probably on. Better, yes, yes, now.
Yeah, ma'am. Ma'am, actually, as you are a rheumatologist, we as an orthopedic surgeon want to know, uh, do you need to stop these DMARCs before any planned joint replacement surgeries in a rheumatologist patient? And if you want to continue some, which are to be continued till what time?
You need to.
So
interpret.
you need to come again, please. We didn't understood
Yeah,
the
yeah.
first part of the question.
First part is that, do we need to stop DMARDs, disease modifying anti-arthritic drugs, if we are planning a joint replacement surgery in a rheumatoid arthritis patient?
Well, this is a little different because we're sort of not talking about rheumatoid, but if you have a patient on, disease remittive therapies for rheumatoid, you stop it usually right around the replacement time until the sutures heal and then you start again. Because usually rheumatoids have more than one joint involved.
Okay,
Is that the question?
Yes, ma'am, that's the question.
Okay.
So
It's a
how
little-
many days before you have to stop it?
Well, I mean, you would, if you have a rheumatoid arthritis patient that needs like a knee replacement, then you need to,
Yes.
you don't need to stop it until the time of the surgery, but then you don't start it again until the sutures have healed to reduce the risk of infection.
Okay, ma'am. So all the drugs are to be stopped or few can be continued? All the drugs are to be stopped? DMARDs? All of them?
He's asking,
Sir.
do you need to stop all the drugs?
Well, we usually, the orthopedic surgeons make us stop the non-steroidal
Yes.
drugs. We stop the biologics or the immunosuppressive drugs because we don't want to increase the risk of infection. And then usually we just treat the patient's pain, if they have any, with some cortisone, either oral prednisone or solumedrol as needed. But usually their sutures heal within
We
2
stop,
weeks.
Disease modifying.
Right, and then you just start again.
Yes.
Sir, for that question,
You can
Yes,
start
sir.
again after.
there is a nice guidelines, National Institute of Clinical Excellence guidelines for rheumatoid arthritis. If only you should stop biologicals. If the patient is on biologicals, like infliximab, mevaparin, or golimumab, you should stop 2 weeks before surgery. You don't need to stop the methotrexate, but you can stop
Yeah.
the steroids.
do that. That's
But
okay.
that's but the nice guidelines.
Have to stop even
But,
immunosuppressants.
Uh,
Stop everything.
yes.
Yeah, yeah.
Usually right up to it.
Even, yeah.
we in
No,
rheumatoid
usually
patients,
we stop all.
all medications, yes.
immunosuppressants and
Right, whether you stop it
biologics,
2
all-
weeks
Yes,
before,
but
2
nice
days
guidelines
before.
said
Before
only
surgery.
biological should stop.
Okay.
Okay, okay,
Hope
ma'am.
you
Thanks a lot for such an
got the
interesting.
answer.
All right.
Okay. So if we don't have any other question from this location, we can move on to Patna, please.
Where are they?
Patna, please unmute yourself and you can ask your question.
Am I audible? Am I audible?
We can hear you, but not clearly. Can you please?
Hello.
try again?
Am I audible now?
Yeah, you are audible, but you're not very clear. So just
I want to.
mic slightly away from your face and then just please try again.
It's okay.
My question is, what is the role of UC2 in type 4 OA or severe OA cases? What is the role of UC2 in severe OA cases?
No, come here.
I couldn't get the question.
No, come here. No, I need you.
You need to come again. Sorry, we can't comprehend what you are saying.
Can you get
Madam,
my jacket?
Madam,
There. Yes.
What is the role of UC2 in severe OA cases?
Okay. So, Dr. Lane, I think, and to the panel, he's asking what is the role of UC2 in severe OA disease?
severe OA,
The role of UC2 in severe OA disease is it might help a little bit, but I don't think it's
it's not suggested.
strong enough that it's going to be effective then.
Yeah,
It's really for early mild to moderate disease. More severe disease, need to visit these
Yeah,
guys. Okay.
yes, yes. UC2 is reserved for mild to moderate only.
Okay.
In severe cases, it is not at all advisable.
Okay.
And also, we would not want to delay a surgery because the longer you delay, the
Yes.
worse outcome.
So what about those patients who are not opting for surgery? Does it has a role or you would not even try? So the disease might be say severe or moderate to severe, but you would offer the surgery to the patient, right? There will be few who will deny it or would like to delay it for as long as possible because that's how it is. So would you still not try any other therapy or what would you do if not UC2, for example?
I think Nancy has tried in even 95 years.
I think the old patient, I've also.
So old is not, need not be,
If,
they may have good
severe
articular cut.
disease, you're just going to give, analgesics and sometimes opioid analgesics if they're not going to have surgery. That's just one that,
If response is not there, there is no point of using
That's right.
in severe OA.
Okay.
Okay.
Yeah.
They can try in some other options, intraarticular steroids,
steroids.
sodium hyaluronate
wear brace,
injections.
things of that
Yeah,
sort.
that is completely pain management.
Symptomatic pain.
Yeah, symptomatic, any genicular nerve blocks like that.
Exactly.
Okay. So any other views, sir? Yeah.
My opinion, steroids only occasional, some in the family, some wedding is there. They want to overcome the any 1 week,
Disability.
10 day or 1
Immediate
month.
relief.
Yeah.
That is the only place where you can recommend the steroid. But in the old age.
Yeah, nice question, sir. In Indian setup, out of 100 severe osteoarthritis, only 20% of the population is ready to go for surgery.
Surgery, exactly.
80% they don't want surgery.
Yeah.
However, if they have insurance or also,
Patient is
they are
not
fear of
willing for
surgery. So in that case, we will give other things like weight reduction, physiotherapy, knee braces and injections, pain relief. If they insist about these medications, we will say that you can try. But we won't force them to take these UC2 medications or nutraceuticals will work in severe. If they insist, we may ask, we may tell, you may try.
Okay.
but not direct recommendation from
They
us
won't-
in
they
severe
won't.
arthritis.
They're in
Okay.
pain. They want something stronger. Okay.
Okay. So any more question from,
Yes, please.
or
I
we
think
can
should sum it up by
shift
saying
to, I think we have a question from Raipur.
that it's
Put
probably
up.
evidence.
Hello.
I really think.
Sorry, sir, you need to come again. We can't hear you.
Hello.
Hello.
Yeah, please go ahead.
Good evening, sir. Good evening, ma'am. Hello.
Hello. Hello.
Hello.
Yeah, carry on, sir. We can hear
Uh-huh.
you.
Is there any clinical evidence that the muscle soreness will not happen after the use of UC2? UC2. Is there any clinical evidence that muscle soreness will not happen after the use of UC2?
Okay, okay. Thank you. So,
Hmm.
Dr. Lane and to the chairperson. So what he's asking is, with use of UC2, does the muscle soreness also reduces? Is there any evidence?
That's a really good question, especially for the audience. Is asking, we talk about the joint pain, but what about the muscles and ligaments around it? It's my impression that as the joint pain gets better, the muscle and ligament pain also improves unless there's been muscle injury and that, or tendon injury. That would be different. But generally speaking, when the knee gets better, the pain at the joint gets better, the surrounding tissues kind of follow suit.
Yes,
Okay.
that's.
Thank you.
Any other
Thank you.
add-on?
What he said is, if it is muscle soreness, but if you eliminate the primary inflammatory response, that is the articular cartilage damage, you are addressing by UC2, they automatically the muscle soreness will come down.
Okay, yeah.
Because
Any
we are
other
targeting
question?
we are eliminating the inflammatory response.
Yeah, it should come down. Yeah.
And soreness will automatically improve. Otherwise, if associated like hamstring strain, tears, it may not work.
Okay.
But
If inflammation is the underlying pathology, then obviously it should help. Okay, got it.
But injury.
Okay, I think we have a few more questions. Any more question from, we're done? Maybe
Is
from
there-
this audience?
Is there any role other than osteoarthritis? Hello.
Where is this question coming from? Online, okay. Okay, yeah, go ahead, please, once again, sir.
Is there any role of this UC2 in other than osteoarthritis, like in rheumatoid arthritis and ankylosing spondylitis, or we are dealing with the many of patient chondromalacia of patella, like in chondromalacia? So is there any role of this UC2 in other than osteoarthritis?
So he's asking, I think we have covered it, but the question is, other than osteoarthritis, is there role for UC2 in other type of arthritis?
Well, I showed a study where they actually used it quite effectively in the treatment of active rheumatoid arthritis. And that was actually the basis of a lot of this work, where the patients developed oral tolerance. But the reason that we don't really use it much in rheumatoid is that we have these wonderful biologics and JAK inhibitors now that pretty much stop the disease progression completely. Although I think in patients that have mild rheumatoid that are maybe on hydroxychloroquine only or Plaquenil, that UC2 might be effective there.
What about
Okay.
chondromalacia?
Sorry, come again?
What chondromalacia, role in chondromalacia?
Oh, I suspect that part of those studies that I showed about the knee pain in the over-exercising group probably had some chondromalacia. And sure, I think it would help a little bit. However, I think the most important thing with chondromalacia is that you exercise and get the patella tracking right. I wouldn't use
Sir,
it alone.
I
You
got
gotta
a
have
few
physical therapy.
audience has texted me, sir.
Sure.
One is by Dr.
Maybe
Srinivas,
come
sir.
on off mute and ask, we can bring the mic to them. Can you just raise your
Hello?
hand if you want to ask? We'll bring the mic to you.
From
Dr.
Madurai.
Srinivas has asked you one question, sir. Dr. Bachu Srinivas, sir. He's asking whether are you going to change the UC2 in a specific targeted people like immune compromised HIV or CKD patients? Do you use cautiously in immune compromised patients UC2? The question
No.
by Dr. Srinivas.
No, there's no evidence that, to say there's no contraindications because it's really, the molecule is broken down. Its activity is most likely in the mesenteric lymph nodes and it doesn't alter your immune system to fight infections. The little bit of IL-10 and IL-4 that it increases does not create an immunosuppressive environment. It's fine.
Yes, sir.
In rheumatoid arthritis, there is a disease modifying agent. Do you think this UC2 is going to be a modifying agent for the osteoarthritis?
Oh, no, I think that, no, I don't, but I think that it is, I believe that UC2 is a mild anti-inflammatory through a different mechanism.
Yes, sir. Last, we got one question from Dr. Sandeep. I think Dr. Sandeep has sent one WhatsApp message. What he's asking, sir, combination drugs like UC2 along with aflapine, boswellia, dicertin, glucosamine, chondroitin, combination is better or isolated UC2 is better? Dr. Nancy?
So, Dr. Lin,
So
combination of
with chondroitin, glucosamine.
Chondroitin
Oh, well, you know,
and UC2.
a lot of,
Isolated UC2.
I think a lot of people take combinations.
Yeah.
And the concern I have about the glucosamine and chondroitin is it does not get absorbed. So if it's working by changing the microbiome and nobody's really studied that. So I can't, you know, I have a number of patients that'll come in taking it and they say, should I take it? I say, well, does it help you? And they say, I don't know. I say, well, stop it and see if your pain comes back. But the mechanism's different and we don't have a strong mechanism for the glucosamine chondroitin. You know, it was popular. Everyone was taking it. The government paid for that study I showed you. But now it's really just sort of gone away almost.
Okay.
It is not going to modify the disease. See, if you are giving the steroid, in a flare-up, you may be giving this steroids. So that time you want us to stop this UC2? See, it will be working 2-3 months. Steroid may be working 2-3 months.
Yeah, you could give, you have a flare, you could give a steroid injection and start the UC2 and then see how they do. Steroids last a month or two and then everything comes back. So see what happens.
Can continue UC2.
Yeah.
Sir, we got one message, from Madhusmita Sahu. She has sent one question, sir. What she is asking is, if you take UC2 with any other medications, that will hamper the Peyer's patches and it will prevent the absorption of UC2.
Oh, no, I don't.
No?
That's a really good question.
Yeah.
I don't know about.
In terms of drug interaction,
Yeah.
there are none as of now. So no known drug to drug interaction or no, absorption hindrance is known as of now.
Okay. Thank you.
And hence it is available as food. So if you see the classification, it is a FSSI food product because the safety is not a concern. It's not a prescription product per se. So any other question before between us and the dinner? Any other from?
Yes,
Be
sir.
close, okay. Yes, sir, please go ahead.
Does the efficacy of the UC2 depend on the severity of the disease, that is mild, moderate, or severe?
I didn't get, sir.
Can
you come again, sir, please?
Can you repeat the question?
Efficacy of the UC2,
Efficacy, yeah.
does it depend on the severity of the disease, that is mild, moderate, or severe?
Sir, I actually, we discussed, sir, this UC2 works for mild and
Mild,
moderate
moderate.
OA only, not for severe.
Sure.
Yeah.
So how efficacy means it works for mild and moderate only, not for
Mild,
severe.
Mild to moderate.
Yes.
Right. People who see me, not
But
you.
also variable from person to person. Some individuals may get good relief, some may get moderate, some may not get any relief at all.
Okay, I think we are done with the question. So may I just thank all the delegates and the chairperson. May I invite Vivek to say bouquet of flower as token of thanks to our
Great
panel.
job, guys.
Yeah.
And thank the audience for all their great
Yeah,
questions.
audience obviously has been wonderful, although they are not that vocal, but they have been writing and asking us questions. All those present here and all those who have joined us online. So on behalf of HALEON, I thank you from the bottom of our heart. Thank you so much for participating. Vivek, can you, so a token of thanks to Dr. Srinivas first. Dr. Srinivas.
Okay, so now. Come on, guys.
Dr. Srinivas. Dr. Valya. Dr. Chandra Shekar. Dr. Reddy. Thank you. Should be giving to last but not least, please. Dr. Lane, please.
No, so everybody. Yeah, oh, what's over there? So somebody can take these ones, just like, take them up. Take them.
Thank you so much. We are now open for dinner. Please join us for dinner, all of you. Thank you so much.